So it's my pleasure to introduce Dr. Stephanie M. Grasso, Assistant Professor in the Department of Speech, Language, and Hearing Sciences at the University of Texas at Austin. As a bilingual speech-language pathologist, Dr. Grasso's research focuses on addressing health disparities among historically underserved and marginalized populations from culturally and linguistically diverse backgrounds. Her work investigates neurologically based communication disorders within the context of bilingualism, aiming to establish effective treatment approaches for bilingual adults with aphasia. She utilizes neuroimaging to examine variability in treatment responsiveness. And additionally, Dr. Grasso's research explores the role of bilingualism as a contributor to cognitive reserve in neurodegenerative disorders affecting language and cognition. Dr. Grasso has published her findings in prestigious journals such as Alzheimer's and Dementia, Brain, the Journal of Speech, Language, and Hearing Research, and Neuropsychological Rehabilitation. So join me in welcoming Dr. Stephanie M. Grasso.
So much, Annie. Thank you so much for the invitation to be here today and to share my work with you all. It's a real pleasure to be here visiting Dr. Kieran's lab, whose work I've looked up to for so long. So today I'll be talking a little bit about my work in bilingual dementia, touching on both characterization and treatment. This work is a result of a collaborative endeavor across a research lab at UT Austin. So I work very closely with Dr. Maya Henry. So across our two labs, we work together to address treatment research in primary progressive aphasia. And then we have international collaborators both in Spain and Mexico who we work very closely with on the projects that I'll be presenting today. To give you a sense of just what we'll discuss today, I'll talk a little bit about patterns we've observed when it comes to age of symptom onset in different phenotypes of dementia in bilingual speakers. I'll talk about some work that we're undergoing looking at the characterization of Mexican American bilinguals with and without cognitive impairment. And then I'll end today by talking about our treatment work in bilingual PPA, looking at the effects of tailored and personalized speech and language intervention. And in this setting, there's no need to kind of elaborate on this theme, but I'll just mention that there's a lot of reasons why we should care about bilingualism. We know that more than half of the world's population is indeed bilingual, and multilingualism is really the norm, not the exception. We also see that bilingualism is linked with policy in many countries, ranging from educational to social policy, and also intersects with social determinants of health. And this figure here is just showing that even in a country, the US, being historically a bit more monolingual in its constitution, we see that the percent of the US population from the 80s to present day has increasingly become bilingual, and there are predictions that this will only continue. So we have real practical reasons to care about bilingualism as well, because increasingly the patients we serve will be bilingual themselves. And in the US, bilingual speakers are more likely to belong to historically marginalized groups. And in the area of Alzheimer's disease and related dementias, or ADRD, we do see that there are significant racial and ethnic disparities in the prevalence of ADRD. Interestingly, though, bilingualism has been associated with a later age of symptom onset in some particular dementia phenotypes, and I'll talk about our work looking at that today. And one theory that has been used to explain differences in age of onset is that of cognitive reserve. You may have heard of this term before, which is really meant to account for the discontinuity that exists between the degree of brain changes that are present, whether they be age-related or pathology-based, and the clinical manifestation of that damage. So it is thought that individuals with higher levels of cognitive reserve will present with dementia onset later than those with lower levels of cognitive reserve. And there are several factors that have been shown to contribute to cognitive reserve and resilience. This is not a comprehensive list by any means, but certainly a few of these factors show up in the literature time and time again, including education, engaging in cognitively taxing leisure activities, consuming particular types of diet, and the life experience that we'll spend most of our time talking about today, bilingualism. And the effects of bilingualism go beyond just some of these behavioral observations. We also see that there is indeed a unique morphology in the bilingual brain. So the bilingual experience sculpts the brain in unique ways. In particular, we see greater gray matter volumes that have been observed in regions that subserve both language and cognitive control. So one question we've been asking in the lab is as follows. In which contexts and neurodegenerative syndromes do we observe an association between bilingualism and age of symptom onset? And today I'll be talking about individuals who have either Alzheimer's disease as well as those with frontotemporal dementia. So I'll just take a moment to define the kind of clinical presentation of these syndromes. So under neurodegenerative disorders, we have different branches, so to speak. And under the branch of frontotemporal dementia, there are three variants. The behavioral variant of frontotemporal dementia, which presents with core changes in personality and executive function. In semantic variant primary progressive aphasia, we see deficits in naming, and this is due to an underlying erosion of conceptual knowledge. And in the non-fluent or agrammatic variant, what we see is that individuals often present with apraxia of speech and difficulties with grammar, so they have a hard time speaking in correct and complete sentences. Alzheimer's disease, on the other hand, has several variants, and I'm just going to talk about two today. The first being the amnestic variant of AD, which presents with these core impairments in episodic memory. This is what most people think of when they hear the word dementia, right? Individuals tend to present with memory impairment when it comes to short-term memory, may get lost, things of that nature. One of the atypical manifestations of Alzheimer's disease is known as the logopenic variant of primary progressive aphasia, where individuals also present with difficulties naming and finding words, but for a very different underlying reason in that they have a hard time with phonological assembly. So I'll be talking about these different syndromes today. And before I talk about some of our work with age of symptom onset, I'll go ahead and just talk about the neuroanatomical and pathological correlates that also make these phenotypes distinct. So with our AD phenotypes, what we do observe in terms of changes in the brain is bilateral hippocampal and mesial temporal lobe atrophy, whereas the logopenic variant presents with atrophy in temporoparietal cortex, which is greater in the left hemisphere compared to the right. And although these two variants typically share the same underlying disease pathology, being Alzheimer's disease, they do differ in the particular brain networks. With frontotemporal dementia, we see different signatures as well when it comes to neuroanatomical and pathological correlates. In behavioral variant FTD, we see atrophy in the frontal lobes. In semantic variant PPA, we see atrophy that's present bilaterally in the anterior temporal lobes, but typically greater in the left. And in non-fluent variant PPA, we see atrophy that's present in frontoinsular regions. Once again, we see different disease entities or proteinopathies that cause these changes. In behavioral variant FTD, we see a mix of pathologies. However, in non-fluent variant PPA, this is most likely to be linked with tau, and in semantic variant PPA, this is more likely to be linked with TDP43. All right, so let's talk a little bit about the evidence that's present for bilingualism as a contributor to cognitive reserve. Some of you may have heard about this finding that there is this 4 to 5 year delay that is present in age of onset in bilingual speakers relative to monolingual speakers. However, there have been some null findings also reported in the literature. In frontotemporal dementia, what's been observed in a study conducted in India was that there is a significant delay in behavioral variant FTD, but not for the other variants of FTD. And although we do see some inconsistent findings across studies, there are many different sources for these inconsistent findings, ranging from a lack of control or consideration of other factors that may contribute to cognitive reserve, differences in the way that we're defining bilingualism and what the particular context looks like for those bilinguals to participate using both of their languages. And one variable that's been described in the literature as well, that of clinical phenotype. So in a couple of studies based with US samples in particular, my colleague and I were interested in looking at potential differences in age of symptom onset, looking at historical data collected at the University of California, San Francisco. What we observed in this AD cohort was that there was a significant delay in age of symptom onset for individuals who had logopenic variant PPA, but we did not observe such an effect for those with amnestic AD. So this is interesting because we're seeing this pattern specifically in this language variant of Alzheimer's disease. And this is relevant because estimates indicate that delaying the onset of dementia on the order of about 5 years would cut costs associated with dementia care by nearly a third. In FTD, we underwent the same process, and although we did not observe a significant difference in age of symptom onset for any of the 3 FTD variants, we think this might be driven by some of the differences we see in the cohorts that we're studying here in the US versus other sociocultural contexts where things like language switching occurs at a much higher frequency. In our current grant with our collaborators in Barcelona, we're also investigating this question in Catalan Spanish bilingual speakers. And this is an ongoing aim, so I'll talk a little bit about our current analyses, but we'll have updated analyses when we finish data collection. As a first pass, what we've done is we've combined our historical cohort and our prospective cohort from Barcelona to investigate the difference in age of symptom onset for individuals that have these 80 positive biomarkers. And we looked specifically to see how passive bilinguals, so individuals in this context in Barcelona, because they're hearing both languages frequently and seeing both languages everywhere, they're not true monolinguals. So they're really more passive bilinguals. And so we're comparing their age of onset compared to active speakers of both languages. We're able to also look at dominance groups because of some questions that were included earlier in this historical cohort as well. And then in our prospective cohort, we're collecting fine-grained information via bilingualism history using the bilingual language profile, which allows us to look at a number of different bilingual factors. So in our combined cohort, what we see in this first graph that I'm showing on the left is that our active bilingual group shows a significant 2-year delay in age of symptom onset compared to our passive bilingual group, and this is in a relatively large cohort. When we look at this breakdown on the basis of language dominance, we see that this is really driven by the Catalan dominant group, which is an interesting finding that we're following up in our prospective cohort. And in part, we find this interesting because in our small sample of prospective data that we've collected so far, we do see that Catalan dominant bilinguals seem to be the group that's showing a significantly later age of symptom onset compared to Spanish dominant bilingual speakers. And we're starting to see some associations between different language history factors, again, pointing towards this more protective benefit in this Catalan dominant group. So just to kind of summarize these age of onset findings and our next steps for this cohort, in our US-based sample, what we see is a significantly later onset in bilinguals with logopenic variant PPA. And in our Catalonia-based sample, we see a significant 2-year delay in age of symptom onset, particularly for those who are active bilinguals and those that are Catalan dominant. So what we're doing now, as I mentioned in this grant, is prospectively examining how particular bilingual factors, including age of second language acquisition, proficiency, confidence ratings, relate to age of symptom onset, and we're collecting biomarker and neuroimaging data to better understand kind of the underlying mechanisms that might be contributing to these differences that we're observing. All right, so with that, I'm going to transition and talk a little bit about our work examining neurocognitive characteristics of Mexican American bilinguals with and without cognitive impairment. Just to give a little bit of background, there have been some studies that have examined differences in neuropsychological test performance in bilingual Latinos with and without cognitive impairment. Some suggest that there may be advantages on general screening measures of cognition, and others have shown that the degree of bilingualism is really important for detecting potential differences in neuropsychological test performance, particularly on measures that assess attention, processing speed, and executive functions. But our understanding of the basic cognitive profiles of bilingual Latino older adults with and without cognitive impairment is lacking. So the first question we asked using this data set was to really try to just establish what these cognitive phenotypes are in Mexican Americans presenting with typical cognitive aging and MCI. The data set we used in collaboration with Dr. Sid O'Brien's group is the Health and Brain Aging Study Health Disparities Cohort. This is a community-based sample that's collected in the greater Dallas-Fort Worth area. And in this cohort, we have a total of 643 individuals who identify as Mexican American and do not present with any cognitive impairment but are aging. And then we have 180 individuals with mild cognitive impairment. From particular measures that they include in this data set, we're able to determine bilingualism status and to look at both language dominance and age of acquisition. So those who are relatively more balanced in their dominance versus not, and those who learned their second language early versus late. And we also have a monolingual comparison group of Spanish speakers in this particular analysis. With respect to the neuropsychological assessment, it's a general battery that includes cognitive screener, measures that tap into attention, executive function and coding, verbal memory measures, and verbal fluency tasks as well. And there's also genetic and plasma markers. So we have information about ApoE, E4 positivity status. And in particular, we're also interested in looking at these plasma biomarkers. So AB40-40 ratio, and this ratio indicates a greater degree of pathological burden when it's lower, and that's associated with worse cognitive impairment. With our participant characteristics, I'll just kind of describe this to you because it is a little bit small, but just to indicate that our participants do differ in the way that we would expect, such that our bilingual compared to our monolingual Spanish speakers have a greater number of years of US residency, they have a higher education and income level, and they have a higher MMSE score. So what we wanted to ask was, do we see any differences just in the cognitive profiles on this neuropsychological battery when we look at mean levels of performance? And subsequent to that, in MCI, do we see differences in the rates of impairment that are present in this population? All right, so I'll walk you through this table. What I'm showing you here in the cognitively unimpaired group are 4 measures that tap into processing speed and coding, where we see significantly higher performance in bilinguals compared to monolingual speakers. 2 of these measures show persistence in the MCI phase, showing this pattern of cognitive resiliency on these measures that are tapping into processing speed and coding. In contrast, bilingual speakers in the MCI phase only demonstrate this pattern of cognitive vulnerability in the form of poor performance on 2 language measures in the MCI phase, being both letter fluency and recall from a verbal learning test. All right, so from here, we wanted to know, are there differences in the rates of impairment when we look at just the MCI group? Because we thought these are really language-based measures where we're starting to see these differences in MCI, and could that just be driven by individuals being bilingual? So bilingual speakers, in terms of rates of impairment, showed lower rates of impairment on Trails A. These were the only 2 significant measures, but higher rates of impairment on letter fluency relative to monolingual speakers. And this was driven by both unbalanced bilinguals and late bilinguals. So we see that it's those particular groups that are driving this pattern. So once again, this pattern really begs the question, could this lower performance paired now with this higher rate of impairment on letter fluency just be indicative of a false positive and maybe be a suggestion that these individuals are bilingual? So to address this question, we examined 80 plasma biomarkers, and what we found was that only the unbalanced bilingual speaker group that had impaired letter fluency had this marker of this lower level of plasma AB4240 relative to the unimpaired bilingual speakers. So what this tells us, again, just keeping in mind that a lower level is associated with greater cognitive impairment, what this tells us then is that this finding of letter fluency is actually grounded in AD pathological burden, is not simply a symptom of being bilingual. So what did we observe? We see this unique bilingual phenotype of MCI in Mexican Americans. There's resiliency that's present on measures that tap into attention and processing speed. We see vulnerability on tasks that are really at the intersection of executive function and language, being verbal fluency. But this is grounded in this pattern of greater AD pathological burden. So this is not merely a consequence of being bilingual. This also demonstrates the need in this population for having appropriate comparison groups to avoid misdiagnosis, potentially premature diagnosis of MCI, because this sensitive marker is emerging only when we're comparing this Latino group to other Latinos. That's when we're seeing this pattern emerge. All right, so with this same data set in mind, another collaborator and I have been interested in investigating the potential for differences in brain structure between bilinguals and monolinguals presenting with typical cognitive aging, MCI, and AD. And of course, there is a lot of prior research in both clinical and non-clinical populations showing that speaking more than one language can indeed modify gray matter structure. But existing work has largely dichotomized bilingualism, so we've not been able to really understand some of the nuances of these patterns, and there's not always been high representation of Latinos. So in this study, we still are using the exact same cohort as before, but we have more participants because we're also including individuals who have AD. So we have a relatively large cohort of participants. We're able to look at language dominance in particular, which was our variable of interest for this study. So we have balanced bilinguals, those who are Spanish dominant, those who are English dominant, and then we have monolingual comparison groups that are Spanish or English speakers. And we were investigating differences in cortical thickness from 34 ROIs that were extracted from the DK Atlas. And for these analyses that I'm going to show you in just a moment, and I'll walk you through the figure because there's a lot kind of going on. We have an FDR correction across the entire set of ROIs. And we used a linear mixed effects model with several covariates of interest, including age, sex assigned at birth, education, and cognitive status. So I'll take a moment to walk you through this graph because, as I mentioned, there's a lot going on, but there's only a few things to really focus in on. So along the x-axis, you're seeing different regions of interest, and along the y, you're seeing mean cortical thickness. And you're seeing this in the left and right hemisphere, first in cognitively unimpaired older adults. The bar graph is structured in a way, if we kind of think of this as layers of cake, as being the thickest cortical thickness group towards the bottom of the graph. And then those that have thinner cortical thickness will appear towards the top. So it's in this descending order, but in an upward direction. In warm colors, you're going to be seeing bilingual groups that are more English dominant. So either English monolinguals or English dominant bilinguals. In yellow, you'll see balanced bilinguals. And then in cool colors, you're going to see Spanish dominant individuals. Okay. So just at a cursory glance, when we look at this figure, what you may observe is that there's a lot of warm colors towards the bottom of this graph, indicating that these individuals and these groups, being English monolingual and English dominant bilinguals, have greater cortical thickness compared to the other speaker groups in these ROIs that were significant. There's one kind of exception to this that you may notice where we have kind of a cooler color towards the bottom. And this is for one ROI in endorhinal cortex, where we see that actually our Spanish dominant group is showing greater cortical thickness. In the MCI phase, we see a very similar pattern, but it's just an attenuation in that fewer ROIs are showing statistical significance. And in the AD phase, what we observe is that the pattern starts to really change here, where now we're seeing cooler colors as well as yellow, because that indicates balanced bilinguals, as showing greater cortical thickness. And what's of most interest here is the particular regions that are showing up. These are entorhinal cortex as well as parahippocampal regions. So these are really disease-related ROIs where we're seeing greater cortical thickness in individuals who are more Spanish dominant or balanced in their bilingualism pattern. All right, so if we see this now just kind of rendered on the brain, particularly for the AD group, this is just showing a couple of those pairwise comparisons. And in that green color, you're seeing these significant differences that are emerging again in entorhinal cortex and in parahippocampal regions. So what does this tell us? We see these unique associations between language dominance and regional cortical thickness across these three levels of diagnostic phase. The presence of greater cortical thickness in the Spanish dominant and balanced bilinguals with AD is suggestive of resistance to pathological progression, particularly in these dominance subgroups. But this is a cross-sectional analysis, and so now what we're doing is we're looking at the same approach longitudinally with participants who have data collected at more than one time point. Okay. So with that, I'm now going to transition to talking a bit about our work on our current clinical trial, investigating the effects of tailored and personalized speech-language intervention administered to bilinguals with progressive aphasia. In terms of prior research that's been conducted, research has really focused on white monolingual speakers but there is increasing evidence that restitutive interventions improve communication skills in progressive aphasia. Very little work has been done with bilingual speakers. There's really been a couple of experimental case studies, as well as a single group study. So in a couple of multi-site trials, we've proven that these two treatment approaches that I'll talk about today have been effective in PPA, showing significant immediate and long-term outcomes, and Dr. Maya Henry was the PI on those initial grants. We've since adapted these approaches for bilinguals and now have our NIH-funded clinical trial underway investigating these outcomes in Catalan Spanish bilingual speakers. The first intervention focuses on naming treatment, and this is administered to individuals with semantic and logopenic variant PPA. And then we have our script training approach for addressing speech production and fluency in those with non-fluent variant PPA. Our current recruitment numbers are as follows. For individuals who are monolingual English speakers, we have a total of 111 participants. For our bilingual speakers collapsed across language pairs, we have 54 participants. And then for the current clinical trial that's underway, these are all of the speech pathologists and researchers working on this project. We have a total of 15 participants that we've recruited data for. We're about a year into our study, and so we're on track with our data collection. So I'll talk a little bit now about the particular treatment for word finding in PPA. Normally what we hear people say is something like, I know what I want to say, but I just can't say it. Or when I'm talking, the words just won't come to my mind. So we've developed this training hierarchy that's designed to really capitalize on spared cognitive linguistic processes, and they're really there to encourage as well self-cueing strategies that we focus on throughout the hierarchy. Participants meet with the clinician twice per week, and they have daily home practice. And it's important to note that we always have individually tailored and functional treatment sets. So we use personal photos that individuals have taken from their own community, their own environment, and we think that this is really important for motivation and for seeing some of the outcomes that I'll report today. Before I talk about what actually happens in the treatment sessions, I'll just take a moment to hopefully, if the audio works, play a couple of clips of patients with semantic and logopenic variant PPA, just so that you can observe some of this word finding difficulty that's present in these variants. All right, and this is in Spanish, I should say, but even if you don't speak Spanish, you'll be able to perceive some of these alterations to fluency. So thinking about the more kind of global profile. So this is a picture that I'm sure most of us are familiar with. So this individual is describing the photo that they see here, and they get stuck pretty quickly into their description where they're unable to come up with the name of kite, which is a low frequency item that's shown in this image. They're able to describe what's happening, but then they can't come up with the word kite, and then they abandon it and don't continue trying to kind of circumlocute. There's other evidence for word retrieval difficulty that we see in the sample as well. In contrast, in logopenic variant PPA, if we just take a quick look at this passage, you'll see that at one point, this participant initially is having difficulty with phonology, kind of part word repetitions are present. Later on, they say, I know what it is, what I want to say, but I just don't know what it's called. And again, it's the same item, being kite, that they're having a hard time with, but then they go on and give a beautiful description, and they're able to kind of circumlocute that instance of anomia. So we see these different profiles that emerge for different underlying reasons, but naming intervention is effective in both variants. And these participants also report very much wanting to work on word finding in therapy. So the hierarchy that's adapted from the Arizona Lexical Retrieval Cascade is as follows. Individuals will describe the item and engage in semantic feature analysis. There'll then be a series of steps that take place, ultimately leading to the individual practicing reading and writing the word 3 times. They'll be asked questions about the item that are semantic plausibility judgments. They'll then recall important characteristics about the item and read and write the word from memory. And then they'll be presented with a complex image with the target embedded, and they'll practice describing what they see and try to use the target image in their description, trying to get individuals to generalize and go beyond the single word level. And individuals also engage in daily digital home practice. So they log on with a link and they practice reading and writing their targets and answering questions to stimulate semantic knowledge about each target. So I'll walk you through the current outcomes of this bilingual clinical trial. I'll start by showing you the effects of the within language naming accuracy and then move on to cross-language transfer. So across the X, you're going to see time, pre, post, and then our follow-ups at 3, 6, and 12 months. And then you'll see naming accuracy along the Y-axis. In this first graph, in cool colors, in this blue and green color, what you're seeing is the effect of trained items in both the dominant and non-dominant language. So we see a significant improvement in naming that's maintained up to a year post-treatment. For untrained items shown in these warm colors, we do see significant generalization, which we attribute to the strategies individuals are training on during their time with us in therapy. But we see that there's a significant difference that's maintained between trained and untrained items. Moving on to cross-language transfer. Here, the blue and red colors are showing us transfer effects specifically for cognate items. And cognates are just words that share both meaning and phonological form, so dentist and dentista, whereas non-cognates would be words that share meaning but don't share form, like door and puerta. So what we observe for cognates and non-cognates is that we do see significant transfer effects for both word types. However, we do see that the magnitude of this effect is somewhat greater for cognate items compared to non-cognates. And I should note that several of our participants are in this follow-up period. So we haven't finished collecting our follow-up data, nor have we finished collecting data for the trial. But when we look at the subset of participants who have completely finished all of their phases of therapy, we do see a significant difference in the maintenance of these transfer effects with a benefit for cognates compared to non-cognates. So we're super curious to see how this will play out when we have our final sample collected. So moving on to treatment for speech production in non-fluent agrammatic variant PPA, oftentimes participants say things like, I just can't get the little connecting words, or I can't speak fluently. So the intervention that we use is a script training approach, which has been tried and true in terms of stroke-induced aphasia. So we've seen so many script training approaches that have come from Dr. Cherney's lab, Darlene Williamson, and others. Our approach is using a combination of different features, and we call this video implemented script training for aphasia, where individuals will practice speaking in unison with an audiovisual model for 30 minutes a day on scripted content that's functional and tailored for each participant. Then they engage in sessions twice a week with the clinician to really promote memorization of the scripted content, and also to promote conversation and using the script in a dynamic way, so it's not just a monologue. We won't hear this clip, but suffice it to say that if you read this, you'll see that there are some grammatical errors that emerge in this individual with non-fluent or agrammatic variant PPA. And we also hear, if you heard the sample, that there's a lot of effort that's put forth in terms of what this individual is trying to convey. So with respect to the actual materials that they practice with, this is an example of that audiovisual model. Of course, they would also be hearing it. And what's nice about this approach is that the level of complexity can vary based on the severity of the participant. And we can alter things not only for complexity, but for things like dialect. So here you're seeing a relatively more simple script on the left versus on the right, a script that's a little bit more complex. The sessions with the clinician go from really structured tasks to conversational usage and functional application. So the earlier steps of the intervention really focus on memorizing the information, making the script production much more automatic. And the later stages really focus on using that in a dynamic way, all the way to using that script in a conversation with just a naive communication partner.
This is all in Spanish, right?
This is all in Spanish, Catalan, and English. Yeah. So here I'm showing the outcomes, and we have the same setup for our graphs. So with the within language script accuracy for this approach, what we're seeing is significant improvement in both the dominant and non-dominant language across time, so up to that 12-month follow-up. However, we don't see any generalization that emerges for untrained scripts. And this is what we expect because kind of the theoretical underpinnings for script training is such that individuals become much more automatic at producing practiced content. With respect to cross-language transfer, we've examined individuals producing the script they trained in their non-dominant language, but asking them to produce it in their dominant and vice versa. And what we see with this cross-language transfer is this significant effect in being able to communicate about these topics across languages, irrespective of the language of training, and that this is maintained over time as well. We're also investigating different linguistic and acoustic measures for trained topics. So just kind of at face value here, what we're seeing and investigating is that we do see improvements on other aspects that are more motoric in nature with respect to production of the script before and after treatment, things like words per minute. And we're also seeing improvements from before and after training on grammatical measures like MLU and morphemes. This data is in our monolingual participants, but we're now replicating and extending this in our bilingual participants. I'll also mention that a project that's very kind of near and dear to my heart that was recently funded by the Alzheimer's Association is a project where we're establishing just acceptability and feasibility of speech-language intervention for language-led dementia in Mexico. We're just starting this project now, but what's very interesting is that the participants that we see oftentimes don't have any other option when it comes to trying to receive speech and language intervention. And these participants also arrive much later to kind of diagnosis. So for that reason, we're also exploring ways that we can kind of extend and expand the continuum of care for these individuals and use augmented forms of communication in conjunction with practiced verbal components of intervention. So we're administering all of this intervention via teletherapy with native Spanish-speaking speech pathologists that work in the lab. We're also very interested in knowing what care partners and participants think about their time with us, what they perceive as potentially improving. And this is just an illustrative example showing that communication partners and people with PPA rate improvements following intervention on practiced skills and also in other aspects of communication like confidence. And some of the things they say are things like, I think that I've improved a lot by practicing the exercises and I've gained a lot of confidence in myself thanks to the sessions. I used to not want to make phone calls because I was afraid to be left without ways to respond. I also avoided going out with my friends. Now I really trust in myself. I can do it and I feel a lot better. And people also say, I think the sessions have benefited me because I've lost the frustration associated with not being able to speak correctly or fluently or rapidly, and I'm able to self-correct without feeling nervous. So what are some of the potent ingredients for these interventions? We definitely think the strategic nature of the naming treatment is very important because individuals can use those strategies in other contexts. From the presentation that took place earlier today, individually tailored treatment stimuli are definitely more motivating. And so maybe that's tapping into some of the plasticity components that were discussed earlier when thinking about motivation and that role along with dopamine. And we also see that the daily home practice to augment sessions with the clinician are very important. For the bilingual intervention, all of our speech language pathologists are bilingual and bicultural. And we've taken care to ensure that dimensions of cultural adaptation and tailoring have taken place, including language, providing education sessions to family members in the languages of their preference, and ensuring that the content is culturally tailored and matched for dialect. The last thing I'll just discuss briefly is that we're also starting to use natural language processing via pipeline in Spanish, Catalan, and in English to be able to identify the metrics that best differentiate different variants of PPA in bilinguals and looking at this on the basis of language dominance. This is with our collaborators in natural language processing. And what we've observed so far, at least in just asking the question of can we use a picture description to differentiate between non-fluent and logopenic variants, is such that the non-dominant language is achieving higher differentiation and that the acoustic metrics compared to linguistic metrics are the most sensitive in distinguishing between these two variants. So we're going to continue with this line of work because it's early for us, but we've finally kind of gotten the pipeline to a place that we're happy with it. So just to conclude today, bilingualism has been shown to contribute to cognitive reserve and resistance in ADRD, but the effects do differ by clinical phenotype and context. Speech-language intervention for bilingual PPA is indeed efficacious and warranted. We see that people get better and that they stay better at least up to 12 months post-treatment, and that in bilingual participants, really careful selection of treatment targets leads to greater cross-language transfer. And so with this, we believe that speech-language intervention in PPA should really be the standard of care and not the exception. This has broad ramifications for service provisions, not only in people with PPA, but also in other neurodegenerative diseases like AD language cases, which we're now seeing in Mexico, who have been historically underserved by rehabilitation specialists. So with that, I just want to say gracias por su atención. Thank you so much for your attention, and I'm happy to take any questions or comments.
That was a lot of material you covered. And you gave us 15 minutes for questions.
Oh, excellent.
Yeah, that was great. I think there are already some questions online.
Okay.
So maybe you could tackle the first one. There is
Absolutely.
questions here. Let me just read the question.
Absolutely. So the first question I see is, what types of measurements or questionnaire sets have you used to establish proficiency in bilingualism? Were you using a threshold to distinguish between monolingual and bilingual, or was this a continuous measurement scale? So we're currently using the bilingual language profile. It's a free measure that's available in a lot of different languages, and we've modified it to ask both pre and post onset questions about proficiency. We've just found that participants with cognitive impairment find it really easy to respond to the question format of this questionnaire. And we don't have a particular threshold when it comes to intervention, being eligible for intervention. It's really just that participants have to report that they are bilingual and are actively using both languages in different contexts. So as long as they have a functional need to use both languages, they'll be eligible for the intervention. And we do get a continuous variable from the bilingual language profile that gives you a dominance index. So you can look at that continuous measure as well. And we plan to use that in analyses down the line, but we're just not quite there yet. That was just someone commenting on some of the pattern that was observed in the non-fluent. How many scripts do you practice at one time? We actually practice one script at a time. We find that for these participants, if you introduce many scripts at a time, it's really hard for them to learn that material. So they're practicing one script at a time, typically 3 sessions for the bilingual participants, but there have been other studies we've published where it's been based on a criteria of accuracy and could range from 2 to 3 sessions. The next question is, in script word production accuracy, where you show improvement in practice script after 12 months, were you able to do brain imaging before the training and after, and at the 12-month follow-up? If you did, what areas showed perhaps better connection or thickness of gray matter? So we are collecting pre-treatment MRI and when possible post, but those analyses for bilingual participants are not complete at this time. So I'm very curious to see those results, but we're going to continue collecting data and then see what we observe with respect to neuroimaging predictors. And then the last question I see in the chat is, what is the difference between dementia and Alzheimer? Dementia is normally used as kind of an umbrella term. And in the past, dementia and Alzheimer's were a bit more synonymous with one another because we didn't have as great diagnostic kind of precision in terms of describing different phenotypes of neurodegenerative syndromes. So now we think of dementia as being this umbrella term with subtypes that might be Alzheimer's, amnestic variant versus logopenic variant.
Great. That was great. You got all of the online questions. Here, I have one. I'll get started. But you have to repeat the question close to your mic because the audience.
Oh, sure.
I thought that the ROI, cortical thickness analysis, It's just really fascinating.
Mhm.
And what you found there was the entorhinal cortex is what seems to be what's different by the time you get to the dementia patient.
Yes.
But can you sort of walk us back to that? And there was a slide
Sure.
that you presented that I thought had a slightly different interpretations.
Sure.
If that's okay.
Would it be this
Yeah.
slide?
So this is the slide where you show that Spanish,
Uh-huh.
the bilingual folks have the highest cortical thickness for the entorhinal cortex.
Who are cognitively unimpaired, right? So we see that in the cognitively unimpaired phase.
Yeah. But
Yeah.
by the time you get here,
Uh-huh. It's really the balanced bilinguals and the Spanish dominant bilinguals that show that difference for cortical thickness.
So that's fascinating, because here it's telling us something about what the entorhinal cortex might be involved in plasticity, in terms of cognitive results.
Sure.
In your next slide.
Of course. Yeah.
Oh, actually, the summary slide maybe. So,
Absolutely.
I wanted you to unpack this. Okay, yeah. So I think that makes perfect sense, but I think I need you to unpack this. Greater cortical thickness in Spanish dominant balanced bilinguals is suggestive of resistance to pathological progression. And what do you think, in your mind, what is the entorhinal cortex doing for this resistance to progression? Like, what is its role relative to the hippocampal or anterior cingulate? Like any other part of the brain, what's special about this?
Yeah, so
with that, doing the Spanish, that might be the harder question.
with the Spanish, it's a little bit harder for us to have a concrete kind of interpretation of that right now. But with respect to what I think it's doing, I do think that entorhinal cortex and parahippocampal regions, which is what ends up being evident in the AD phase, I think both are contributing likely to memory. I do think that there's probably some difference when it comes to kind of memory that's going to be evident in these groups, particularly when we start to look at dominance. And because these are really disease epicenters of AD, the fact that we're seeing that cortical thickness being more robust in the AD phase for these Spanish dominant and balanced bilinguals, to me indicates that for whatever reason, they're showing better preservation of this disease-related region, which is indicative that there might be some kind of resistance that's present to kind of atrophy in a region that should be affected by AD. So with endorhinal and parahippocampal regions, when you look at some of the correlations in kind of healthy populations, you'll see this association, kind of episodic memory, right? And so one thing that we're really curious to do is just look at the correlations in this Mexican-American population that are cognitively unimpaired and better understand the associations between entorhinal cortex and some of the cognitive measures we have in this data set, because some of the basic assumptions that we're making, unfortunately, are coming from samples where there's not been the best representation of these different racial and ethnic groups. So I don't even think that we can take a full guarantee that we're going to see the exact same associations between cortical thickness and behavior, right? So that's kind of our follow-up to this, is to go ahead and look at these associations, ensure that we're seeing these associations between parahippocampal, entorhinal cortex, and memory-based measures in our cognitively unimpaired phase. And if that's the case, then what this suggests to me is kind of this resistance to the underlying disease pathology.
That makes a lot of sense. But I also feel like there's a different way to think about this, because at the end of the day, if it boils down to the entorhinal cortex and parahippocampal gyrus, then again, like all the other studies you interpreted, you said it's about the disease. It's not so much about which language you use and how much you use it, but it's the fact that by the time you have dementia, your brain's changing a certain way. This is what you have left, that may be the genetic marker or this cortical thickness. And so in that case, maybe the speciality of the entorhinal cortex is the way certain cultures access memory with a lot more emotion and language. Like maybe it's less about cognitive working memory and blah, because that seems to be tied into the way you use your language and the way you use the language and cognitive interaction, but it has more to do with how the memory systems just stay resistant over time, and it has to do with how people access that memory.
Interesting.
I don't know, I'm just thinking about it, because at the end of the day, if it's less about the cognitive control
Mhm.
measures and more about where in the brain you actually see the least amount of decline, it seems to be less about memory. And
Yeah, that's very
working memory
interesting.
better and more about long-term memory. Just my way.
Yeah,
of
so some kind of
interpreting
combination of kind of the access of memories via emotional connection. Okay, yeah, that's
or the way you use
yeah.
language to
Uh-huh.
get into that system.
Absolutely.
So there's more language and emotion involvement for other people. It's less, and this might just be a cultural thing.
Difference.
It just seems like that
Yeah.
seems another, not
Sure.
opposite to, not in contrast to what you're saying, but just a different way to think about.
Yeah, no, that's really interesting. I'll take a look and see what other measures, because there are some qualitative measures that are captured in this data set to see if there's anything that could address that. But I think that's a really interesting idea.
You mentioned like comparing Latinos to Latinos. However, in the US, in Spanish, English bilingual communities are very different a lot of times. And so like in Austin and in Texas, there is a long history of bilingualism and there is a lot of bilingualism in general. And if you think like English monolingual, Spanish monolingual, and like a truly balanced bilingual in the middle, there's people all across the spectrum. Whereas in a place that there isn't or doesn't have such a long history of Spanish English
Cross-cultural, yeah.
right, there may be, you know, you might have like from generation to generation big gaps between levels of bilingualism. And so I wonder if you collected the same data from another place that might have like a different pattern of bilingualism, if you would see the same results.
You might want to summarize that question. So
I
to the audience.
I don't know, it was more
It's
like
Yeah.
a thought than
Yeah.
a question.
Yeah. The question is essentially, because Texas has a long history of bilingualism kind of embedded within the state of Texas and the culture and the history of Texas, would you maybe see a different pattern in studying the same population, but where the language profile may differ, right? Yeah, I mean, I think it is possible. I think that there are some commonalities between Mexican-American populations in Texas and let's say California. I think that there are some similarities kind of in the Southwest. So I'm not sure that I'd expect to see vast differences there, but I think if we went to a totally different part of the country where the sociocultural kind of environment for Mexican-Americans differed, there could be differences. I'm not sure though if I would expect
what she's saying is also that in Boston, for
Yeah.
example, you wouldn't see Mexican Americans.
Mhm.
You would see what?
Oh, absolutely. I definitely think there would be differences if we're talking about different subsets of Latinos. Absolutely. There's no doubt because there's even well-documented differences in like language switching behavior amongst different groups of Latinos. So absolutely, I think that there would be differences. So this is very specific to kind of the Mexican American population.
And then another thing I was kind of bouncing around in my
Yeah.
head was, for example, Cuban American population in Florida. There is a lot of words that they've kind of taken in from English. So like cake is a K,
Mhm.
like essentially cake. So I wonder if words like that would, I mean, of course it would, but
Yeah. I mean, you definitely see different levels of kind of anglicizing words in different contexts. Like you see that also in Texas. So you'll see like washateria, which is not a word that really exists, right, in terms of like Spanish, but it is kind of this mix of English and Spanish. And so I do think that there's kind of there are contexts in which you may not know, is that truly kind of speaking English? Is it Spanish? Is it code switching? Right? But I'm not sure specifically how the degree or the number or percentage of anglicized words would kind of have an effect on something like this.
Yeah, it's your data on cognates is the closest to explain.
That's exactly right. Yeah, that's the best I have.
I'm so excited.
Yeah. No, of course.
You said that you were hoping to collect MRI pre and post treatment, how are you gonna quantify? I mean, I don't know how like far apart your time points are, but for neurodegeneration.
Yeah. So the aim of the grant was to collect pre-treatment data to look at predictors of treatment response, to look at predictors of treatment response in each language, and then also the transfer effects. The post-treatment data is just being collected because we were able to do so because of how we're going about collecting the data. And my colleague has some interest in looking at even just kind of resting state and things like that from pre to post treatment to see if there's any potential change. It's about a 4-month period. So we will be able to quantify the amount of volume loss that has taken place during that period, which would account for neurodegeneration, and then overlay kind of the resting state connectivity on top of that. So there's longitudinal ways to look at volume loss over time.
Stephanie, you have two very good
Oh.
questions online, and I'm
Yes.
actually interested in the second question.
Okay.
But maybe you can.
Yes. Okay. First one, can you repeat the outcomes you observed with Vista, using Vista with NFV PPA? Of course I can. Let me go to that slide. All right. So what we see with this treatment effect is that for both scripts that were trained in either the dominant or non-dominant language, people get significantly better in producing their scripts, and this is maintained up to a year post-treatment. We don't see significant transfer to untrained scripts. We don't expect that to be the case because the theoretical underpinnings for script training are really based on automation of practiced content. And then for cross-language transfer, we do observe that for topics and scripts that the individual was trained on in one language, they automatically get more fluent at producing that content in the other. So those are the effects that we see for script training. Oh, and then any observations about code switching in bilingual PPA? We're coding that right now, actually in CLAN. We've not found an automatic way to code or tag code switches. I'm very interested in this because we definitely see it emerge. We see it more frequently in the logopenic and the non-fluent variants relative to the semantic variant, just in terms of anecdote. But right now we're coding these behaviors so that we can actually try to better characterize them. Yeah.
Are the code switches compensatory or more like pathological?
Yeah.
Can you repeat that question?
Yeah, the question was, are the code switching behaviors more compensatory or pathological in nature? With logopenic variant PPA, it tends to be very compensatory. So it's like the phonology is more challenging for some reason. In one, maybe you've experienced this if you've ever learned a second language and you have a word that you're trying to say that's a little bit more complex and it's easier to say it in the other language for some reason, right? We definitely see that in logopenic variant PPA where it seems to be a little bit more compensatory. In the non-fluent variants, it's a little bit of a mix because some of our participants have more frontal damage where they have difficulty really inhibiting one of their languages. And so in that case, it gives the impression that it's a much more kind of pathological behavior where they're upset that they're not able to kind of stay in one language and they're kind of switching back and forth. But some of our more mild non-fluents, it seems to be a little bit more compensatory, again, for the motor speech reasons, that for whatever reason, it seems like the motor plan for a particular word may be easier for them in one language versus the other. I can think of a participant who was an English-German bilingual speaker, and because words in German tend to be a bit longer, the individual was kind of reverting towards English as kind of a strategy. Mm-hmm. Yeah. Yeah.
I'm curious, sort of like in like a structural sense, how do you deal with the progression of disease states among participants? So, for example, how have you dealt with in the past participants who are logopenic at one point, sort of progressing to like an AD diagnosis versus like non-fluent variants or progressing to like a Parkinson's plus syndrome or something like that? And how have you sort of have you created like a PPA plus group in the past, right? Where at one point they had qualified for a diagnosis and later on, I know other people that we've talked to that do a lot of PPA research, I say, you know, the thorny problem flows, but I can imagine it's even more difficult to deal with perhaps in a bilingual sphere where participants have to have these diagnoses and then they're bilingual, right? So it's harder and harder maybe to let the classification go. So I'm curious how you deal with that.
You definitely have to repeat that.
Yeah, the question is, thank you for reminding me. The question is, how do we deal with individuals who start with a particular PPA, maybe a canonical PPA diagnosis, and evolve to a different syndrome based on their symptoms? So it's a good question. In our treatment studies, because it's really a year interval, it's been very rare that someone would have progressed to a completely different syndrome, particularly because in this restitutive intervention, we have some inclusion criteria where individuals are really in the mild to moderate stages. There have been a couple that have progressed to PPA plus kind of in the follow-up period. But because they began and when they really were receiving the intervention, they had a canonical PPA variant, we consider them as that variant because everyone eventually will convert to PPA plus. Nearly everyone will, right? If they live long enough because of the spread of atrophy and cognitive impairments that arise. And following kind of the strictest criteria, depending on how strictly you kind of follow the Gorno-Tempini criteria, when you start to see those levels of involvement with cognition, it may automatically become kind of PPA plus. So I don't know if that really addresses your question, but we don't see drastic changes in the canonical variants. And when we do, it typically is in the follow-up period, at which point we're really looking for maintenance and not necessarily looking at the immediate treatment effects by each canonical variant. And we do also enroll mixed cases. So we do see some mixed PPA cases, but they don't get included in the canonical presentations because they have a very different response to treatment. Yeah.
Okay. I think we'll wrap this up. Thank you very, very
Thank you very much.